also thank you guys for inviting me to talk today. So the title of my talk is New, Not Necessarily Improved, and I'll be talking about implementation of new information systems and as well as new platelet products in the transfusion service with kind of a pediatric hospital focus. And so the objectives for the talk is really to talk about some of the benefits and gaps that we have in our informatics tools for preventing inappropriate blood administration. And then at the end, I'll touch a little bit on how we implemented new blood products. This is kind of top of mind, I think, to everybody as there's a new FDA guidance and there's implementation of new platelet products across the country. And kind of talk a little bit about what we're going to do at our pediatric hospital and utilizing these products. And so, I'm a junior faculty member and kind of thinking about implementing all of these kind of new information systems and platelet products, and kind of some things that have helped me through this time has been something I'd like to share with all of you to see if that also kind of helps you as well. And so one thing that, if you guys have ever heard Dr. Mike Astian, who is kind of chief of labs at Seattle Children's talk, and if you hear him talk about lab management, he always kind of talks about these three things, and I wanted to really share that with you because it kind of helps ground me too when we kind of have to make decisions and kind of implement these projects. And so, so he says, lab management is about staying calm, avoid extreme thinking, believing people want to do a great job, so people come to work and they really want to do a good job. And then three, editing and prioritizing what comes top down. And so, we had to do a lot of that because the institutions have these projects on to implement. And then also, thinking about, I also like this quote, is that upgrades can be downgrades. And so, it's kind of going along with, not to be cynical, but that we're kind of sensitive to the operations as laboratorians and how that really can affect our operations. And also, when we're thinking about kind of these big projects, I think it's important, and what helped ground me too is kind of thinking about, and I'll keep coming back to this, is what is the intended kind of goal of all these project implementations. And really the goal has been, blood safety, having blood available, and having the highest level of transfusion safety. And in doing this safe transfusion process, we're ensuring that the right blood gets to the right patient. And so that's kind of something that you'll kind of see throughout this talk is going to be a big part of the focus. And so, that has been the focus, and there's been a lot of work in the transfusion service at Seattle Children's before I joined in order to kind of accomplish this. And so I wanted to kind of give you guys a little bit of that context for the talk. And so it started really in 2011. So there was a big project. So Puget Sound Blood Center, now known as BloodWorks Northwest, kind of implemented a lab inside the Seattle Children's Hospital along with Seattle Children's leadership. And so the lab was on site, but it was administered by BloodWorks Northwest. And there was kind of a hybrid model. So the build was, there was the blood bank kind of information system was BBCS. And so that just stands for, I think, Blood Bank Computer System. And so that was the system where they would do the cross-matching and have all the history, and all of the documentation would be in BBCS. But there was a little partial build of Cerner. So we started to capture a little bit of history there. So some of the results would go through Cerner, so some of the ABO types, and then also some of the transfusion history. So if the patient got transfused, it would be in Cerner. And then, of course, there were blood orders already in Cerner as well. And there was a big project kind of in 2014 to 2015 time period to revise those blood orders. And so then, and that also included revision of how the transfusion profile information, so the information that the patient's transfusion requirements, how is that communicated to the lab? And this was pretty successful in terms of decreasing. One metric that we often follow in transfusion services is a cross-match to transfusion ratio. And I'll be talking a lot about cross-matching throughout this talk. And so it's how many units did we set up and cross-match for that patient compared to how many actually got transfused. And generally having a cross-match to transfusion ratio less than 2 is good. And, at the start, 2011, it was already pretty good. It was somewhere around like 1.9 or 1.8. And then it was, as the lab was on site, it actually got brought down even more. And then with kind of a revision to blood ordering, it got down to like that next level of, right now it's more like 1.4 is our cross-match to transfusion ratio. And then so I kind of joined in 2017 Seattle Children's, and then we had another big project in terms of we wanted now to have the blood bank be administered by Seattle Children's. So the transfusion service would be Seattle Children's administered, it's Seattle Children's staff, Seattle Children's SOPs, and it's the Seattle Children's blood bank module, which is Cerner at the time. So Cerner was not only the electronic health record, but it was also now the blood bank information system starting 2018. And then as you guys know, and you guys recently implemented Epic, so we also then turned around and then implemented Epic in 2020. And with that, Epic doesn't have a blood bank information system, so we had to implement a new system. And so the one that we chose is Informatics SafeTrace TX, and so that is something I'll talk a little bit about as well. Okay. So talking about like implementation of these new information systems for transfusion service specifically, I kind of wanted to talk about what are like the big pieces that we should be thinking about. And so something that we did implement some of with Epic is positive patient identification electronically for specimen collection and for blood administration. So I think that has been a big gain and is a very important for transfusion service. Blood orders are another big important part. So as I mentioned, there was a big project in 2015 in Cerner to kind of revise the blood orders, and then we did that again with the Epic. And then blood bank information systems is kind of where I want to spend some time talking about is how do you implement a good blood bank information system and kind of what is the goal of that blood bank information system. And so I kind of list here a few things. The main thing is to prevent an ABO or IHD-incompatible transfusion. We're also using it to document and evaluate test results, have that result history, know what the patient's transfusion requirements are. We're tracking all the units, the processing, the disposition of those units, and then the patient's transfusion history. And then there's also a billing component. And then as we're changing between different information systems from BBCS to Cerner to this Informatics SafeTrace, we had to do data conversion. I'm not going to talk too much about data conversion, though, today. So what I wanted to focus on now is really talking about how does the blood bank information system allow us to prevent that ABO-incompatible transfusion. And so to do that, I first wanted to kind of take a step back and just make sure we're all on the same page about pre-transfusion testing and what that entails and kind of the history of how that evolved, which is something I recently learned. So, I think we're all taught we should get a type and screen, and the type is the ABO and RHD type, and the antibody screen tells us if there's any other non-ABO related antibodies in the patient's plasma. And then the cross-match is that, okay, I have this patient's plasma here, and it might have IgM antibodies, might have IgG antibodies. I wash that with the donor red cells, and then I can see if that agglutinates or doesn't agglutinate. If there's agglutination, it's incompatible, and if there's not agglutination, it's compatible. And so this is kind of what is a serologic cross-match, and then there's different components to this serologic cross-match. And so if we're looking for IgM antibodies, which is what the ABO antibodies are, then we just need to do an immediate spin cross-match. So that's kind of what I showed on the previous slide. Just take the patient's plasma, mix it with washed donor red cells, and then see if there's agglutination. Now, if we're looking for non-ABO antibodies, those are usually IgG antibodies, we actually need to use an additional reagent, and we have additional incubation time at 37 degrees Celsius, and trying to see, this is an anti-IgG, we often call it anti-human globulin or Coombs reagent, and so that actually can help to agglutinate those and detect those IgG antibodies. And it was kind of the standard before 1984 to do this kind of more time and labor intensive cross-match that included both the immediate spin and this AHG anti-human globulin cross-match. And it wasn't until the mid-1970s when we started to utilize actually a type and screen, and it was thought, well, actually the type and screen and the reagent red cells that we use in the screen can detect whether a patient is going to have clinically significant antibodies. And so I'm just citing and showing a table here from a paper from was published in 1977, but in it they examined more than 12,000 samples that were tested in 1975, and they showed that the type and screen was more than like 99.99% effective in preventing transfusion of incompatible blood. And then you can see on the table the types of antibodies that they missed were like anti-Lutheran or anti-HR, anti-VS, anti-BW, anti-KPA, anti-Rite A. So these antibodies are really rare, and those are the ones that we're not detecting on our reagent with the reagent red cells. And so in 1984, actually, the ABB standards allowed that, if you do the type and screen and you don't see any clinically significant antibodies, then, and that's your history, then you can actually do this immediate spin cross-match. And so, that was, what was happening there in the 80s, and it was in the 1990s that then people started to, with computerization and implementation of blood bank information systems, it was realized, oh, well, there's actually some limitations to this immediate spin cross-match, and maybe there's a better way to do that, and a safer alternative could be an electronic cross-match. So this is showing an editorial from 1991 from John Judd showing that he talks about what are the limitations of that immediate spin cross-match. There can be false negative reactions, there can be false positive reactions in the presence of like cold antibodies, and it's not really useful in babies who don't actually have IgM antibodies for the first few months of life and don't have those ABO antibodies. The immediate spin cross-match is not something fruitful. And so, there's an idea to actually do this electronic cross-match. And then I kind of pulled out the last paragraph here where he's saying, like what's stopping us though from actually implementing that? And I think it's still the same things that are kind of stopping us now from implementing new processes in blood banks. So we have a lot of accreditation requirements, a lot of regulations, and then there's also an investment of money that's involved in sort of implementing like a new information system or a new technology. So, this is something that they're really working on in the 90s, and the ABB standards did get updated to actually have, include what is the requirements that you need for an electronic cross-match. And there were institutions that started utilizing an electronic cross-match. And so they would have to apply to the FDA, so it wasn't part of the code of the Federal Register yet. And so they actually would apply to be able to use an electronic cross-match. And they'd have to show that they have a validated computer system. There was logic to prevent assignment of incompatible blood. They needed the two ABO determinations was present before. And it seemed, when I was reading some of these prior articles, there was always kind of maybe two camps where maybe some people did do retyping on one sample and then others would require two different samples. And then now we know that our standards do encourage to have two different samples to prevent any identification errors of the patient ID at sample collection. And then there's still this history of no clinically significant antibodies, because then you'd want to do that serologic AHG cross-match. And then kind of this last bullet is bringing up what are the kind of other things that the blood bank information system helps us with, and having a computerization in the lab help us with. So, barcode scanning of specimen, barcode scanning of units, having confirmatory testing of the donor units in the computer system is necessary, and having like computer verification of the interps and those results. Because if it's not done by the computer, then it needs to be manually verified by a second person. And then having this history of the current and the historical results. And then this kind of surprised me in terms of, the electronic cross-match was, thought to be a safe alternative. And then the FDA did have a final ruling to include that you could either do a serologic or an electronic cross-match in as long as you met these requirements. And that was in 2001, but it's kind of been a slower adoption than I would have thought to using electronic cross-match. So in 2004, based on like CAP proficiency testing surveys, only 2.5% of the labs were utilizing this electronic cross-match. And then, the FDA actually did a draft guidance regarding computer electronic cross-match, and maybe the numbers started going up to 16.5% in 2010, and then there was a final guidance in 2011. And when I look back at we do these JACE survey CAP proficiency testing, and looking back at the 2019 and 2020 surveys, it looks like there's about 3,500 labs that are actually participating in these proficiency testing surveys. And so what they do is we get sent like different samples and different units, and we test the ABOs on them, and then we're telling CAP if we think they would be compatible or incompatible for the patient. And there is an electronic cross-match portion that you can opt to do as well. And only about 1,000 of these labs out of like 3,500 are participating in that electronic cross-match proficiency testing. So that's only about like 30% of the labs utilizing that. So I'm not sure if that really reflects like how much has been adopted in the US versus how many are agreeing to do the CAP proficiency testing for it. But it's clearly helped. So having a validated blood bank information system using electronic cross-match has clearly helped decrease the rate of ABO-incompatible red cell transfusions fatalities. And so this is something that was recently reported in 2020, and it's the FDA, kind of what's been reported to the FDA from 2000 to 2019 on these ABO-incompatible RBC transfusion or mistransfusion fatalities. So from 2001 to 2009, there's about 1 per 2 million red cells transfused was calculated to be result in an ABO-incompatible fatality. And then in 2010 to 2019, that rate is much lower. It's only now 1 per 7.14 million red cells. So it still happens. And overall, in all the cases reported from 2000 to 2019, about 80 total, they determined like the primary error, was it the clinical service or was it the transfusion service? The majority was in the clinical service, like about 58, maybe 46 in this period before 2009, and then maybe another 12 from 2010 to 2019. So it has gone down over time in the clinical service, especially with implementation of like two-person verification and electronic patient ID. But in the transfusion service side, the number is lower, so it's 22 in the whole time period. And in the time period from 2010 to 2019, there was only 5. So it was like 17 before 2009 and only like 5 more recently in the last 10 years. And nearly all of those cases that were those incompatible transfusions were manual process failures. And so I think that really stood out to me, is that we know we're most at risk when we're using manual processes, and using the blood bank computer system is really increasing patient safety. And so it also speaks to having good workflows for downtime as well. Okay, so just talking, I talked a lot about how we do the electronic cross-match, and I think electronic cross-match is something that is like newer and improved, and it definitely improves practice. And so, as I mentioned before, it prevents improper ABRHD product selection, but also decreases turnaround time for blood, it increases staff efficiency, and then by doing that, staff can really pay attention to patients that have like ABO discrepancies or clinically significant antibodies, so they can put more attention where it matters and can do more different process improvements. But no blood bank information system is perfect. So we've used a few systems now at Seattle Children's, and one big thing that stands out for me is kind of how important the user interface is for these systems. And so I think, so having a blood bank information system is definitely an improvement, but kind of moving to a new one, I think you get kind of less improvement. And then also depends on kind of the flexibility too of the system that is implemented. So in terms of like how can you build that system to really meet the workflows of your institution, and what does that system allow? And so that's also something that we learned with kind of implementing these different information systems. And especially when thinking about kind of the flexibility and the ABO, I think, using a standard ABO compatible table, I think, is pretty straightforward and is a very good foundation. But there's always these other scenarios that kind of come up, and you have to make decisions on how you're going to handle that. So one is like you have an antibody, but you don't know the specificity, or you have an antibody, but it's clinically insignificant. How do you want your computer to handle that situation? And we're a pediatric hospital. We see a lot of ABO discrepancies. So we have neonates who don't have a back tip. They're over 4 months. They don't actually start developing ABO antibodies, but we still transfuse them. We have a lot of stem cell transplant patients, and if they're an ABO-incompatible transplant, there can be discrepancy, or even just from receiving chemotherapy, there can be a lot of discrepancies. And so how do we still utilize electronic crossmatch in kind of our system to handle these scenarios? And so that's what I wanted to talk about kind of in the next set of slides, is how we do that. So here's an example of an ABO compatibility table for red cells, and it's kind of a way to show how the system prevents that ABO-incompatible RBC transfusion. So just as an example, here you can have hard stops where you have like the white in this table, and then the purple is like a warning and the gray is no warning. So if you have a patient typed as group A, the system is not going to allow you to release AB and B red cells. That's just not going to be allowed in the system at all. Now, if you're an A-neg patient, then it could allow you to release an A-pos red cell, but only with a warning. And so that's just an example of how the computer system helps prevent incompatible transfusions. And then, you can kind of improve upon this. Like one example for us, an improvement was with platelets and trying to adapt that to our pediatric hospital policy, which is that we don't give out-of-group platelets for patients less than 2 years of age. And we also try to obtain provider approval before giving out an RHD-pos platelet to an RHD-negative patient. So if our patient is like Rh positive, then there's less warnings because they can get any Rh-neg or Rh-pos platelet. But so if your patient is A-neg, then they can receive like these A-neg or AB-neg platelets only without a warning. And then for any other scenario, we'll get a warning, and they have to our technologists or lab scientists stand up, pause, and think, oh, are they less than 2? Do I need to plasma reduce? We also have a lot of ABO-incompatible transplants where we try not to give out-of-group platelets, so it makes them pause to think about doing that plasma reduction. And then, we actually were able to kind of create those platelets into another category of plasma-reduced platelets to also decrease those warnings. So we talk about clinical decision support in the EHR side. We also have this is kind of clinical decision support on our blood bank information system side. And so if we have that warning or override fatigue, to reduce that, we were able to create kind of this new category for platelets that are plasma reduced, because that can actually, those are compatible with all patients. And so that was a big improvement for us, and these were implemented with our Cerner blood bank module. And then, so I mentioned we do a lot of ABO-incompatible transplants, and how do you allow electronic cross-match still for those patients with ABO-incompatible transplants? So I think that's not something that everyone does, but we do allow electronic cross-match in these scenarios because we have very good control and define what these patients can receive. And so we do have separate tables that define new ABO compatibilities. For these patients, we created new blood types that allowed that. And so this is just an example showing that in our institution's policy, we only allowed group O RBC transfusions for our ABO-incompatible hematopoietic cell transplants. And so this is kind of what that table looked like. So if they were assigned this new blood type, you could see like all of them could only get like O neg or O plas red cells, and if they were Rh neg, only Rh pos with a warning. And then you could still further adapt that farther based on institutional policy. You could maybe create different ABOs. We didn't actually implement this, but there are scenarios where a group of transplant involving A and AB antigens could get group A RBCs, and so you could build out your tables to kind of account for that scenario as well. So that's kind of what this is showing. And then because I talked about platelets before, I kind of just wanted to show, what those platelet compatibility tables would look like in our system with those new transplant ABOs. And we actually did implement it with a hard stop, but you could choose to do it more with like kind of a warning scenario as well. So we had hard stopped to giving out of group platelets if they were an ABO-incompatible transplant protocol, if they're full volume, and then the plasma reduced table looked the same as before. Okay, so this resulting of a non-standard ABO, it has pros and cons. So the pro was that we could prevent inappropriate issue of blood products based on our institutional policy. It was a clear visual flag for our clinical staff that this patient kind of has an ABO-incompatible transplant and a non-standard ABO compatibility table to look for. And the cons were that, it does, if you have like an emergency event and massive transfusion, it does add additional complexity maybe to giving out emergency products. You have to have a good plan for that. And then we didn't have computer verification of the ABO types in these settings. And so, but we knew it was safe because we were giving group O red cells. And then there's education and adjustment to new processes and implementing that. And so what I've been talking about really is kind of this highest level of control with ABO compatibility, but there are different levels that I wanted to talk about. And so at the bottom of that pyramid is, okay, we have patient comments, you have history, there's no computer-based control to prevent issue of an incorrect component. And so this is an example of the hospital just has to look, the staff has to look at the ABO-incompatible transplant, and based on these instructions, choose the right product. And the computer doesn't stop you at all. What we were able to implement with our newer system is to use kind of transfusion requirements to control those, kind of offer that same level of control. For an ABO-incompatible stem cell transplant, they can only get group O RBCs. We can add a group O RBC only transfusion requirement. And you can implement that to be warnings or hard stops. And then same with like antigen antibody matching. You can implement something to say this patient should only get D negative RBCs. Even though they're Rh pos, we think they have a partial D, so we only want to give D negative RBCs. And you can institute that level of control with different transfusion requirements. And then like what you choose and how you choose to utilize it really depends on the information system, as I mentioned, and the flexibility of that information system to accommodate those builds, and also the kind of internal institutional workflows and policies that you have. And so here I'm just kind of showing you some of the examples that I already talked about and how you would utilize them for each of these types of levels of control. Okay, so in this first part I talked a lot about blood bank information systems, and in the next part I wanted to talk a little bit about kind of our transition from the Cerner electronic health record to the Epic electronic health record, and kind of what we thought about what we wanted to do to maintain this, again, blood transfusion safety in this new system. And so here I was thinking about kind of different, again, these work-life maxims that have kind of helped me in these first few years. So one I came across was one from Dr. Joseph Simone, and he said one of his #1 maxims was institutions don't love you back. And so it sounds kind of cynical, but really it did help me think about how the institutions have their own priorities and they have their own timelines and what they want to accomplish. And the things that we're doing at work, when we're coming to work, it's really those relationships we have at work, it's our coworkers, it's our patients that we're serving that are really what's making our experience there. And so with that, again, just kind of thinking about blood safety and availability and transfusion safety. And so kind of when we are implementing these big projects, always coming back to kind of why we're doing it, and it's really to ensure the right blood to the right patient. And so when we went on this journey to kind of go from Cerner to Epic, we had some help to kind of think about how we were going to use our electronic health record to maintain that blood safety and transfusion processes that we had already built. And so, so this is something that I just wanted to kind of show you about how we're thinking about our overarching goal was to, to have safe blood administration and prevent any patient harm events. And then I showed you already some metrics that we had about having a good cross-match to transfusion ratio, maintaining low wastage, and then the things that were driving that. So blood ordering, specimen collection, blood administration, how we're distributing the blood, and how we're monitoring these transfusions. And then these were kind of some of the things that we thought were the interventions that we had in our electronic health record that helped us and drove us to reaching these goals. And so I'll focus a little bit and tell you a little bit about what we did for blood ordering. And so the order is really important because, it's how you're communicating with the transfusion service, and that information in these communications are going to flow into our blood bank information system, and we're going to use that information to issue the blood products to the patient. And so we have not only an electronic order, but we also sometimes receive, verbal guidance, and then some of this information does flow electronically into the information system, but some also requires some manual entry and manipulation. But ideally, you would have everything would be kind of streamlined and connected, and this is kind of what is the kind of our ideal goal, and something we tried to center around is, what's in the transfusion profile and the electronic health record should be populating kind of the orders that the blood bank uses, and then those orders should ideally flow into the blood bank information system, and that order should match whatever the nurse is seeing or the transfusionist is seeing to transfuse the patient, and then we should have the complete documentation of that event in the electronic health record and the blood bank information system. So that's the ideal kind of goal, and how we're trying to accomplish that is, this is kind of some examples of an order set from Cerner of how we kind of had a different forms, electronic forms, where they could enter, this patient has a consent, this patient needs irradiated blood, and this patient needs pre-medication. So there are different, there are some forms that could be pre-populated and that would carry over across encounters in that patient's record. And it was getting pulled as text into our Cerner orders. And then some of that information, like the attributes that were important for the blood bank to prepare the right product, would get printed onto the lab rec that would print in the lab. And so we wanted to maintain kind of a similar process in moving from Cerner to Epic, and to know so the EHR knows we have a specimen, and so it has logic to say that, hey, you need a specimen. It has that pre-medication information. There's still a form now in Epic that can get populated and then pull that text into our blood administration order set. A big improvement for us was ordering in mils and units. And then blood orders still have this way that you can have special requirements that are pre-populated on a profile that does carry cross-encounter and populated in the order, or those can be changed in the order and saved in the profile for future encounters. And so this is just another example of kind of what that order would look like, and this is in the inpatient side, kind of what the blood special requirements looks like, and then you can have this is kind of an improvement as well, the display on the an order report on the side of the order that has a lot of the information that you need and you're looking for in real time as you're placing the order. Okay, so So with the blood ordering pathway, there were a lot of changes that were implemented actually in 2015 and 2014 period. And so before 2015, I would say, there was, multiple orders, is my understanding, multiple order sets, and there wasn't much guidance in those orders on how to order. It was hard to find orders. It was hard to find the type and screen order. The care teams didn't know if they needed a specimen. There wasn't a lot of visibility on specimen expiration. There wasn't visibility on whether a product was available. So there were higher kind of wastage, cross-match to transfusion ratios. And so we had all these problems in that pre-period. But once, we kind of figured out what are those problems, so in 2015 they were able to actually hone down and implement that, we can just have one order that is the prepare order for the blood bank and the transfuse order for the nurse. We can have these blood special requirements that can cross encounter. We can have guidance on specimen requirements and good visibility of specimen expiration date, good visibility of the products and the expiration date time of the product. So we had that already with this 2015 Cerner blood ordering kind of revision. And so when we moved to Epic, we did maintain a lot of those things, and so I'm really quite happy with that. But really, it's just more of an adjustment now. So and adjusting to kind of how things work in the new system. So I definitely think that we can use our electronic health record to improve blood safety, and we'll continue to improve upon that. And so, you guys have just implemented Epic here at UW, and so I know at least when we implemented Seattle Children's right after, we had like hundreds of tickets related to blood bank and going through and challenges to think about. And sometimes, it can feel like a little bit of a step backwards and thinking about, I just think this is something that kind of helped me as we implemented Epic, and afterwards I just bring it up here. So I listened to this TED Talk by Mark Rober called Reframing Challenges and the Necessity of Gamification and the Super Mario Effect. And so the Super Mario Effect I thought is interesting in that he's saying, when you're a kid, I played Super Nintendo too and Super Mario Brothers. I don't think I ever saved the princess, but I was trying to get to that next level and kind of the goal of that. And we didn't focus on is Mario going to fall into the hole, or oh man, I can't believe I did that. But we're thinking about oh, I'm going to remember next time when I play, I'm going to actually skip over that, and how am I going to overcome that challenge? So I think having like that perspective and always having that kind of goal in mind on like why we're doing this, and kind of learning from those experiences is something that I think really helped me also with these like implementations. And so for us, we're thinking about like why we're doing this. Again, just bringing back to always thinking about blood safety and what is our overall goal, and we're always going to continue to try to iterate and improve on this process. Okay, and so with that, so the next thing that we did was really implement new platelet products. And so this, again, is another step that was kind of decided more by an FDA guidance to promote blood safety in terms of transfusion-transmitted infections. And so because I've been talking a lot about implementation, I just wanted to show kind of the different areas that we thought about with implementing the new platelet products. So we had a project manager, Don Hoffer, who helped us to kind of stay on track. I think that was really important, and kind of categorize kind of where the different work streams and what work we needed to do. So we weren't able to incorporate this work when we went live with our Epic Go Live, so we did it post-Epic. And so you can see here that the work we did in the transfusion service was in the blood bank information system. So our blood bank information system has a product table, so we had to categorize, like each blood product has a electronic code associated with it, and we have to define that. And as products are modified, they have a new E-code, so we can like keep track of that history. And so it's a very large build. It's like one bullet on here, but it's a very large build to build out all these product tables. I thank Bill Johnson at Seattle Children's for that. And then we have these patient kind of transfusion requirements I mentioned, or special needs. And so thinking about how you utilize those when implementing a new product. So in this case, we implemented sorrel-treated platelets, which could substitute for irradiation. Billing kind of gets into play when you have new products. And then the information system has its build, but then you also have kind of a different system for generating standard labels. So there's a Hematrack system that you have to think about in the transfusion service, and making sure that the labels that print match what the product is. And then there's a transfusion report attached to the product. So there's also this other, it's printed out from the blood bank information system, and that is how the care team knows that this product is the one that was intended for this patient. The blood bank intended this product for this patient. So that's kind of the things we're thinking about on the transfusion service side that we changed. In the electronic health record, I talked a lot about orders, and so just thinking about, is there anything in process instructions that need to change? And then again, blood special requirements. So if the blood bank information system's changing, you might need to change your electronic health record and those requirements. Communication to the lab. So we have ABO-incompatible transplants, and we have kind of electronic forms that we needed to update. And then kind of interesting, so I mentioned there's these electronic codes, or E-codes, that we use for blood products, and they are the letter E with like 4 digits. And then there's been so much new products in blood bank recently that they actually had to change it to be EA and then 3 digits. And that's actually a big change for an information system. And so, so Epic had to kind of go in and upgrade and accommodate for these new codes, which were not only related to new platelet products, but also to COVID-19 convalescent plasma products as well. So, so kind of like all these different streams that implementing new products can change. And then with implementation of anything new, you have new training. So we have our lab staff that are training nursing, other transfusionists, I think always remembering anesthesia, important, the providers ordering the blood products, and then kind of developing all these like training materials for the lab and the hospital staff. And then finally with support documentation, for us, sorrel-treated platelets are new, but also platelets and platelet additive solution, which is the past platelets here, it was new for us. So we had to accommodate that in our ABO compatibility charts and tables in the blood bank information system, and in our kind of support documentation, and then in all of our hospital and lab policies and procedures. Okay, so that was kind of about the implementation, but like, why were we implementing it? So really it's kind of to target this transfusion-transmitted infection, which has been really low from administration of blood products. The safety of blood has increased tremendously over time. So this is just a graph from this blood paper from 2019, kind of showing in the top panel is what has been the rate of, this green line is HIV over time, and then the red is hepatitis C virus, and the blue is hepatitis B virus. And we can see that the rates have dropped to more like 1 in a million or less since the implementation of nucleic acid testing and antibody testing, antigen testing over time. And the second panel is kind of showing how the cost of a red cell has increased over that time period as we've increased the number of tests that we're doing in donors, how that has impacted the cost, although the most recent tests implemented like Zika did not come with an increased cost. And then the last panel is showing about kind of like emerging pathogens that have come up, and some have been implemented via asking questions on the donor history questionnaire, and some have been implemented via these tests that as I mentioned, and then some have come up, but it's just been a transient thing, or it's not something that has really impacted the blood supply. And so the idea that what has been the target for blood safety now, the FDA has been focusing more on kind of this idea of bacterial contamination, and then these sorrel-treated platelets also help with this emerging infections. And so, what is kind of the risk from bacterial contamination? So this is just kind of showing that data from the 2019 FDA reported fatalities, and over time there's maybe been about 4 deaths per year due to bacterial contamination of apheresis platelets, which is maybe about 1 in 500,000 platelet transfusions in the US, maybe that can result in a fatality. But it's not really only just the fatality, so this is kind of perhaps an underrepresentation of, there are non-fatal septic transfusion reactions that could also be prevented, and so maybe that rate's more like 1 in 1,500 to 1 in 3,000. And so the FDA put out a guidance in 2019 about bacterial risk control strategies for platelets. And so with that, the blood suppliers have to now implement new additional bacterial testing for platelets or soil treatment of platelets. And so the blood supply has changed, and I'm not going to go into the details of all the ways to meet that, but just kind of give you the bottom line of what we're doing. So now our platelet inventory has moved to an only apheresis platelet inventory. So whole blood derived platelets have been phased out, and we are able to, though, still aliquot from apheresis platelets. So we're a pediatric center that does a lot of aliquoting for small patients. And then we've implemented platelets and platelet additive solutions. So the American Red Cross is our kind of secondary supplier, and they're moving to an inventory that's all in PASS, platelet additive solution. And they're really moving to a majority soil and treated platelet inventory as well. Soil and treated platelets are these kind of pathogen-reduced platelets, which I'll talk a little bit more on the next slide, and they can be in plasma or PASS. So the soil and treated platelets, as I mentioned, are considered pathogen-reduced, and so the idea here is that there's a soilin compound that can be added into the platelet after collection, and then it goes under UV irradiation. The soilin gets in and into any of the nucleic acid that's in the bag, so in not only any pathogens that are in there, but any like white cells that are in there as well, and then it makes them no longer viable. And then the soilin compound's removed, and now you have a safe platelet product that doesn't have pathogens. But as you can imagine, there's a lot of manipulation and processing that is required for this process. And also very kind of strict requirements that make it more complicated on the blood collection side as well. So we're a pediatric hospital, and so kind of focusing on, are we going to implement these soil-treated platelets? And so, in terms of safety, the data does show that it's safe in our in pediatric patients, and so we are going to implement these soil-treated platelets and kind of use them interchangeably with our other conventional platelet products. But then, there's another question that kind of comes up. Well, what about like the efficacy of these soil-treated platelets? And so, kind of what the data has been showing us on the efficacy is that, there isn't any increase in significant bleeding events in these studies. So here I'm just showing kind of just one little panel from multiple outcomes, but one showing kind of that the risk of like clinically significant bleeding, like 7 days following either receiving a soil-treated platelet versus a standard platelet, they didn't have increased bleeding events. Now, most of these studies were in adult hem-onc patients. Another interesting thing, though, is that they did show that, these new platelets, they did require more frequent transfusion of these platelets, though, in the arms that were receiving these soil-treated platelets. So even though there was no more bleeding events, they did receive an increased number of transfusions, and it's likely because they had lower count increments, and then they also saw there was a smaller interval to the next platelet transfusion. So, some of the data that's cited to kind of put that efficacy question in perspective is there was a platelet dose trial performed and published in 2010 kind of showing that If you had a high dose platelet of 4.4 times 10 to the 11, a medium dose 2.2 times 10 to the 11, and a low dose of 1.1 times 10 to the 11, does that affect outcome? And they looked at hematology oncology patients, more than 1,000 adults and almost 200 pediatric patients, and they transfused these platelets if they had a platelet count less than 10,000. So it's kind of a prophylactic platelet transfusion count threshold. And what they saw is that, the platelet count itself did not predict whether they would have more days of bleeding. And then also that how much platelet dose you gave also didn't affect kind of how much these patients bled. And so that is kind of shown in this next slide here, at least for the adults. I'm trying to get my mouse to work. So if your platelet count was less than 10,000, there was a little bit of increased bleeding. And then from 10 to 80,000, there was no difference in the days of grade 2 or higher incidence of bleeding. If you're above 80,000, then you do have less days of grade 2 or higher bleeding. But in general, in pediatric patients, no matter what your platelet count was, you had more days of grade 2 bleeding. So whether it was less than 10,000 or 60,000, you had similar days of bleeding. And so kind of taking kind of that information all together and thinking about like, what do I need for my service or my hospital? That's kind of what we had to think about first, is what is going to be our policies when we're implementing these new products. And so kind of the things that we considered is one, what was available from our blood supplier. And so I kind of told you we have 2 blood suppliers, and are we going to accept all the products that they offer or only a subset? We ended up saying we're going to accept any product platelet product and type of product, and build for all of those products. There's also, have to think about acceptance of low yield platelets. As I mentioned, there's increased complexity on the blood supplier side now with these new products. And so, to have platelets in inventory, we might need to accept low yield platelets. So we built out for that. And then I mentioned talking about kind of the soil and treated platelets. Are we going to accept them? And are we going to use them, interchangeably with the conventional and irradiated platelets? And we did decide to do that. And then finally thinking about, what is our patient population that we're serving at our hospital is something to consider. And so we are not a trauma hospital. We do have massive transfusion events. We do have patients on ECMO and receiving cardiac surgery who are effectively massively transfused, but not from trauma. And so kind of the consideration there is we want to have platelet products that are rapidly available, and you want to make sure they have intact coagulation factors that will function to help promote hemostasis. So in our institutional policy, we are more focused on kind of this idea of sometimes I have pediatric patients who have very limited line access. They're small patients, and that platelet product can give them plasma along with the platelets. And so in the massive transfusion event, we are going to try to give preferentially platelets in plasma. So that's going to be one of our policies. And then, we see a lot of hematology and oncology patients, and these are kind of our high utilization group for platelets. So thinking about, that's why we're going to accept any platelet that we can get for these patients. And they have frequent transfusion reactions. They have, thinking about their high utilization, we might think about how platelet increment and survival kind of also comes into play here. And so we are preferentially utilizing platelets in PASS for these patients, and as I mentioned, taking all acceptable kind of platelets for these patients. And then I already mentioned that, we're a pediatric hospital, and in terms of kind of safety and then donor exposure kind of considerations are what come up a lot in pediatric patients, but really we've moved to an all apheresis platelet product inventory, and we're kind of viewing all of our products to be equally safe and interchangeable. So I kind of just, thinking about now kind of the impact of this guidance on bacterial risk control, that's called Bacterial Risk Control for Platelets from the FDA. I think, I can appreciate trying to decrease reaction risk. We know that these sorrel-treated platelets can decrease transfusion-associated graft versus host disease, not necessarily the large volume delayed sampling platelets, which is with additional bacterial testing, and these other things that they've implemented can decrease septic transfusion reaction and, kind of help us prepare for emerging pathogens. But, to like what, what is the other side is, how is it going to affect the quality of the platelets, the availability of it in our supply? And so thinking about, I think, I'm not sure which way this is really going to end up tipping the balance towards, because I do feel like it adds complexity, increases utilization, and decreases efficacy. And with that, I think I kind of just wanted to think about, what is kind of the future of blood safety and transfusion safety. And, it's not just about that transfusion transmitted infection in the blood product, but it's the whole process. And so I just wanted to leave you with just a few ideas about what I'm thinking are the opportunities and barriers for the future. And so we talked about positive patient ID as being something that's very helpful for specimen integrity and blood administration. So I think the barrier really is getting adoption of that in all hospitals, and then kind of improving that process so that we can really utilize it. There still are wrong blood and tube events even with electronic positive patient ID. So how can we really improve those processes? I think, there is a need for, better reagents, better testing, better blood bank information systems, and we can make improvements on that. I think it's hard because there's kind of seems like a limited market, limited number of blood banks, and, a lot of regulations. So although there's some things that I think would be great to improve, I think that's difficult. And then, we've been talking about these new platelet products and how it affects kind of quality and efficacy, but I think, if we can do research to really lengthen the safe and the high quality storage of blood products, that would be a big advance. Adoption of new technologies, though, always takes time in our system. And then kind of this different things in transfusion practice that I didn't talk about is kind of, there's EHR clinical decision support that we'll work on, kind of new ways for inventory management. And then finally, like kind of in the hospital, we have this culture of patient safety, which I'm very thankful for. And then some of the barriers, though, that we always think about is kind of what is the focus of the institution, the metrics they're using, and kind of what's the finances situation to kind of implement some of these technologies that we talked about. And so with that, I think I just wanted to acknowledge kind of first all of the transfusion service staff, and then kind of there's a lot of leadership that has been there. Before I joined Seattle Children's, there was already a very robust transfusion service, and the Blood Utilization Committee was headed by Dana Matthews and D. Townsend McCall previously, and they did a lot of work to improve the quality and safety of the blood transfusions, and Megan Delaney had great leadership there prior to my joining, and then all of the lab leadership and all of the blood bank information system and EHR build teams. And so with that, thank you.
So I don't know if Monica's trying to say. So here's a question from Andrew Bryan. He says, thanks, Mika, for an excellent talk. I'm curious how the experience with Epic Blood Product Administration alerts for nursing has gone at Seattle Children's Hospital. If you're using them, and what is your process for overriding those results?
So I guess I don't know if it's asking about the barcode scanning. So we have kind of like a new bag function, so that tells you like that this blood product was intended for this patient, and we do not, if they are not able to use that electronically, our process is they have to call the blood bank. Was that meant to be that unit for that patient? They could either send it back, we try a new unit, or we don't really do an override, I guess. They'd have to do it on downtime. So I don't know if that answers the question.
Thank you. I have one more question. You commented about more transfusions with sorrel-treated products. Are you seeing that at Seattle Children's?
Not really yet. It's hard for me to tell right now. I think it's really early, and kind of when I talk to other transfusion services, I think it's kind of subtle and it's hard to know, because even with our hem-onc patients, sometimes they're getting platelets every day, whether they're plasma platelets or sorrel-treated platelets or past platelets. So I think it's a little bit hard to tell, and I think we'll need more data. We've only done this since April, so very few. And the few we've looked at, I don't think I've seen anecdotally a difference.
Okay. One more question from Hamilton Sang. He says, with our EPIC rollout process, we've seen some steps forward in our workflows, but also many steps backwards where things are currently dysfunctional. And so, as someone who is farther along in the process, have you gotten to a place where you have been able to patch up all the gaps that have been formed?
Yeah, there is a light, I think, at the end of this. Yes, I think in the beginning, like in the first month or two post our EPIC go live, we had, like I mentioned briefly, like hundreds of blood bank related tickets and things and ideas for improvement and how to stabilize. And some of it is really adjustment, and we are now at a point where, you know, we're now starting to think about more optimization, and we have been able to patch up a lot of the things. I mean, some of it I think we're just, you know, used to it and they're okay with it, and I think we'll probably, once we have time and energy, kind of come back to thinking about, okay, are we ready to really make an improvement now? Like it is a problem, but maybe it's a problem that people got used to. It's something different, and so I think yeah, we have definitely more stable now than we were in October, November.
Well, I don't see any more questions. Unfortunately, we can't hear Monica here in the room. So thank you, Naviha. I think that was a great talk. Really appreciate you coming to talk to us.
Thank you.